radiologically positive parametrium and node followed by HDR intracavitary brachytherapy in cervical cancer, a prospective institutional experience. Over to you, Dr. Sharmin.
Thank you, dear moderator and distinguished chair, faculties, and today's audience. Assalamu alaikum and very good evening. I am Dr. Lieutenant Colonel Shaila Sharmin. I am classified specialist in radiation oncology working in Combined Military Hospital. On behalf of my department, I am going to present this session. This is one of our ongoing project for 5 years. I have picked up 1 year data and going to present, and this is on locally advanced cervical cancer. So my topic name is dose escalation to radiologically positive parametrium and node using VMAT and SIB followed by HDR brachytherapy in locally advanced cervical cancer. This is single arm perspective study. These are the common main points for next few slides. We shall go through this. I have already said this is ongoing 5-year project. It will completed in 2029 in December. So I have picked up 20 cases, those who are included in our inclusion criteria, 20 cases, and we have taken our ethical clearance registration in 2024 February, single center based and its prospective study. Now, what is the rationale? So you see, in case of loco-regionally advanced cases of cervical cancer, it is solely on radiation part. I'm saying that EBRT and ICRT have to complete within 7 to 8 weeks. So when we use sequential boost, it will not allow us that time period. That's why that's why it is important to complete as a simultaneous boost in case of disease burden side as well as the nodal positive side. Another one is the convenient, it also for the patient, and it give us local control and survival rate, same as the conventional one. Now, volumetric arc therapy with simultaneous integrated boost allows radiotherapy dose escalation to the region of involved node as well as parametrium, and simultaneously reduce toxicity to nearby important wear. Our study objective is to accurate thing is the cover total dose volume histogram based plan evaluation to achieve equity to 80 to 85 gray, max up to 90 gray to the D90 of HRCTV, that is high risk clinical target volume considering the normal tissue constraints. This is the endpoint actually for the whole thing, that is 5 years, but now I would like to express that only acute toxicities and early response assessment is the main motto of this study of 1 year period. I would like to share some clinical trials and guidelines related to our study. This is evidence-based, what we have done. Here you are seeing that this is consensus guideline for delineation of clinical target volume for intensity modulated radiation therapy for intact cervical cancer and update. It has been established and published in American Society of Radiation Oncology Journal 2024 April. And this is a compact guideline for concurrent chemoradiation plan. Here you see, this is Indian Brachytherapy Society incorporated with European J-Castro and American Brachytherapy Society recommendations for CT scan-based contouring. So what we have done in our center, this is CT-based. We don't practice MRI-based contouring, actually. We have not that facilities. This is J-Castro guideline summary. This is a benchmark toward the shifting from the 2D to 3D era, especially MRI-based image-guided adaptive brachy. Here, I can show something like, you see, initially this is the huge growth, and only on brachy, we can't cover the side wall part of the growth, especially the parametrium and lateral pelvic wall. That's why total dose, whatever required for the curative intention, have to complete with EBRT, followed by local dose we should cover with ICRT. As we know, as per radiobiological point of view, brachy has only central dose coverage is very good option, but due to sharp dose fall, you can't cover, this can cover the lateral wall. And this is another image of J. Castro guideline. Here they have shown where it is GT, that is gross tumor volume, the high risk CTV and the intermediate risk CTV. So. This is another study, Embrace study. This has been conducted by J. Castro of Gynae Oncology Group. They have conducted these three study. This is Embrace 1, Retro Embrace and Embrace 2. This is the previous one. It has been conducted from 2008 to 2015, including about 24 distinguished centers of America, Europe, and North America. Both of this consensus guideline for EBRD as well as shifting to MRI-based brachytherapy, and it is published in Lancet UC in 2021. Another one is Embrace 2. This is the final one, and we can find the total compact planning and contouring guideline as well as the total 50 days coverage, how we incorporate with concurrent chemo and the brachy in last 2 weeks in this way, or we can do in this way and also in 5th week and 6th week as well. So this is a final guideline and it's published in ESTRO 2025. Here you see Embrace 2 published in ESTRO 2025. And finally, this is our radiation oncologist Bible, we can say. This is ICRU 89. This is solely for brachy of cervical cancer. And there are more slides. This one is an important literature review published in New England Journal of Medicine in 2025, May or July session anyway. This is a compact literature review for cervical cancer. Here all and everything is incorporated in this literature. So in my study, we have included age between 18 to 75 years, histologically confirmed locoregionally advanced cases, and definitive concurrent chemoradiation followed by brachytherapy. So within performance status, ECOG 0 to 2. And these are the exclusion criteria, just alternative of those, especially the if any history of surgery or history of radiation previously and performance status more than 3 as per ECOG. So method, especially method, I would like to say that whatever we do in our center, before simulation, we do pre-simulation patient review and assessment. Every weekly, we have 2 multidisciplinary board. This is our general practice in our center. After having completion of multidisciplinary board decision, we do CT simulation as per guideline. We do 2 to 3 millimeter slice image in contrast guided, and as well as empty bladder, comfortably full bladder protocol and empty rectum. And thereafter, after having image, we do target volume delineation and dose evaluation, after having that, plan evaluation and approval. When a plan is ready to deliver, we do every patient quality assurance check. After having passed the quality assurance during treatment, daily basis we do image checking by KV image matching, and in first week, every consecutive 3 days, we do CBCT followed by weekly CBCT for confirmation of the setup verification. And these are the few slides I shall go through first. These are the target volumes. Actually, in our TPS, we have done this. You are seeing these are the internal iliac nodes This is the obturator nodes. We do contour in this way and with a short margin 3 mm in a curative dose. In This is another slide. You see, as the node positive, so prophylactic parametric node we have also irradiated as 45 gray in 25 fraction. So these are the other few slides. This is the brachy slides, plan evaluation slides. This is the evidence based of Nancy latest edition where we do follow. This is the wear guideline, and this is our RT dose prescription. We dose escalate up to 54 to 56 gray for para, and for node 57 to 59.40 to achieve this equidito dose. And we have to keep an eye during plan evaluation for all of this. This is the OAR dose constraint, and we do every weekly OPD follow-up to check acute skin toxicity, routine investigations, and management at patient complaint. These are a few slides we shall go through for result analysis. In our center of 20 cases, we have found 45 to 50 year range patient more. Stage 2B is most of the patients are stage 2B. Few patients we have given NSCT, especially 3 weekly paclitaxel carboplatin, 3 cycle, and a few of interlace trial. This is phase 3 trial, and weekly paclitaxel carboplatin for 6 cycle. And those two are stage 3 C2 or 4A. We have practiced for 3 weekly. And most of the patient you see not received any neoadjuvant chemo. We straightforward went for concurrent chemo radiation as most of the cases of our stage 2B. In case of ICRT, we used 6 gray 4 fractions more, as well as some amalgamation of 7 gray 1 fraction or 5.5 into 4 or 5 gray in 5 fraction, whatever is required for achieve equidito of 85 to 90 range. So these are the regional positive. Most of the cases are parametrium. This is the follow-up. We have found 9 cases complete response and not assessed within 6 months, rest of them. Most of the patient did not complain for specific toxicity. Grade 1 we have found 6 patients and grade 2 for only 2. Lower GIT toxicity is less, cystitis is more common, and it was found in 3 patients. Skin toxicity, grade 1, frequently we have found. This is loco-regional evaluation, and this is part of our data sheet. This is our study limitations. You know, this is a single center based study, and immunotherapy not used in my study in stage 3-1 and stage 3-4 as a concurrent and maintenance, but we have planned for next year we can apply Pembro as a concurrent for stage 3A to 4A cases as per guidelines. So treatment with VMAT and SIB in carcinoma cervix, significantly pelvic lymph nodes, shows very good response with acceptable acute toxicities. So, but longer follow-up period is required to evaluate response for better disease-free survival and overall survival outcome seeing. These are the references. I have a video, I think not enough time, so I would like to give thanks to all. This is our part of our cancer center team. Many more are posted outside. We have medical oncologists, radiation oncologists, physicists, our oncology nurses. In last 21st November, this was one of our picture. So on behalf of my department, I acknowledge my departmental activities. I would like to conclude. If you kindly allow, then I would like to show last video. And thank you from my side. Assalamu alaikum for patience hearing.
Thank you, Dr. Sharmin, for your such a brief presentation.
So this is actually the total scenario, what we do in our center. This is patient setup. image verification. Here we confirm our total dose and then execute treatment. This is our Linux 2.7 variant machine. Treatment is just going on. In our practice in pelvic cases, we do actually VMAT in almost all the cases. Here you see the bird's eye view, how wear has been saved. And after completion of EBRT, this is the arc therapy, volumetric arc. It can be given only few minutes, 3 to 4 minutes treatment can be completed. And this is part of brachy. And thank you so much